This talk is about Barr diplopia chart interpretation. We will specifically be talking about Barr diplopia chart interpretation in a patient with right inferior rectus weakness. This talk consists of a brief introduction and the answer to 5 key questions. The purpose of the introduction is to create a figure that will help us answer the 5 key questions. So let's start. These photographs of a patient with inferior rectus palsy caused by a metastasis were published by Dr. Xu and Dr. Dimmer back in 1998. I will use them as the basis for discussing Barr diplopia charting in patients with inferior rectus palsy. In health, the function of the inferior rectus are depression, extorsion, and adduction. Under action of these muscles will lead to elevation, intorsion, and abduction. I have now introduced a cartoon of a patient with the eyes in primary position and the extraocular muscle. I am indicating the right inferior rectus under action by coloring the inferior rectus muscle black. Notice in the cartoon that the right eye is hypertrophic, that is higher in relation to the left, and as it is in the real patient, intorted as denoted by the little white trapezoid being close to the nose in the cartoon. Compare it with the normal rotational position indicated by the white trapezoid in the upper pole of the left eye. And also note the right eye abduction in the cartoon and in the patient. In this frame, I have placed goggles with a red crystal on the right and a green crystal on the left. The curved arrow just introduced indicates a twist of the body to display the head as seen from the back. The position Barr diplopia charts are recorded and interpreted. Now you can see the back of the head, and using artistic license I have drawn the eyes as if we could see them through a transparent skull. Here I have introduced the Barr diplopia chart corresponding to a patient with right inferior rectus palsy. Now let's bring the first key question. Why there is no double vision when looking up? The reason for the absence of diplopia when looking up in patients with inferior rectus weakness can be easily understood by remembering that the inferior recti do not contribute to up gazes. In this frame, I am indicating the contribution of the inferior recti to the different gazes by the width of the arrows. Notice that there is no arrow going up. So the answer to this question, why there is no double vision when looking up, is because the inferior recti do not contribute to up gazes. The second key question is why there is double vision in all gazes except when looking up. Looking at the Barr diplopia chart, it is easy to confirm that double vision is present in all gazes except when looking up. This figure, previously shown, depicts the inferior recti functions, and as you can see, it includes arrows going in all directions except the up gazes. So the answer to this question, why there is double vision in all gazes except looking up, is obvious, because the inferior recti contributes to all gazes except when looking up. The third question is, why is diplopia crossed? This question takes a little explaining. The term cross diplopia indicates that the image belonging to the left eye is displayed to the right of the image belonging to the right eye, and the image belonging to the right eye is displayed to the left of the image belonging to the left eye. This is the result of the loss of the abducting power of the inferior rectus that produces eye abduction. The reason excessive abduction leads to cross diplopia is convoluted, but in the next few minutes we will unravel it and package it in a neat bundle. In the right corner of this frame, I have introduced a figure corresponding to the normal visual pathways leading to monopia. I have now introduced the normal visual pathway coming from the left fovea macular area and the images reaching the occipital cortices. In this frame, you can see the representation in the calculating area of each hemisphere. Now I am representing the right eye looking through a red crystal. The axis of vision of the abducted eye falls in the temporal retina, where I have represented the red bar. The fibers from the stimulated ganglion cells in the right temporal retina travel uncrossed towards the right calcarine area, where the image is represented and drawn here and now depicted in the cartoon representation of the right hemisphere. Ultimately, the brain perceives the white bar as two bars, the true image, the one from the unaffected eye, and the false image from the right eye, displayed to the left of the true image. So the answer to this question is because adduction weakness produces abduction that displays the image of the bar towards the temporal retina, and as the result, the false image is on the opposite side to the affected eye. The fourth key question is, why is the false image top tipped to the right? In a patient with right inferior rectus weakness, extorsion weakness leads to intorsion, as depicted by the little white trapezoid indicated by the arrow. I have placed a curved arrow to indicate a twist which brings the face forward, keeping the eye in primary position. Fundoscopy in a patient with intorsion will reveal that the disc is lower than the fovea. As you know, the fovea and the middle of the disc should be at about the same level. In this frame, I have introduced on top of the retina the anterior segments of the eye, and now a white bar at about 1 meter from the patient's face. The image of the bar is then modified by the anterior segments of the eye and captured in the temporal retina, as indicated here. Now let's imagine we could do the same, but looking at the fundus through the red crystal of a goggle, so that the retinal impression will be red. In this frame, I have cleared lots of elements to only represent the red image of the bar in the retina, as you can see here. I have now extended the line between the macula and the disc to the temporal retina to represent the spatial relation between the line and the bar. In this new frame, I am representing their idealized transportation to the cortical retinal representation. As you can see, since the position of the disc and the macula in the cerebral representation of the retina is normal, the bar will be represented with the top tilted away from the discs. In this frame, I have isolated the cortical representation of the retina and the bar, and now move it to the left of the screen and reintroduce the representation of the patient with right inferior rectus weakness. Notice that the top of the bar is tilting towards the right ear. Once again, I am using the curved arrow to indicate a twist that will allow us to see the head from the back, and as a consequence change the position of the cerebral representation of the retina. Notice that the top of the bar is tilted towards the right ear, which is reproduced in the position of the red bar in the bar diplopia chart in all cases. So the answer to the question, why is the false image top tipped to the right, is because intorsion weakens, produces extorsion that rotates the disc below the macula, altering the rotational position of the bar in the retina, which is then transmitted to a normal rotated cerebral retinal representation. The fifth question is, why is the false image lower than the true image? To answer this question, let's first talk about optics. In this frame, you can see some key elements involved in making vision possible. The cornea, the pupil, the iris, and especially the lens have a major effect on the way the retina captures an image, just as much as the optic pathway and the cerebral cortex has on the way an image is perceived in our imagination. Suppose an image is viewed with only the right eye, the image in the retina is captured upside down and reversed, then the upside down reversed image will be transported to the visual cortex, where a map of the retina is present. The retinal map is for vision no different than the sensory homunculus for cutaneous perception. It has a point-to-point strict correlation between receptors and cortical representations. In this figure, I have represented a cortical map on the right retina viewed from behind. Think of the position of the retina as if someone would be viewing your right retina, hence the disc is towards your nose and the macular is towards your right ear. In this view, I have added the image as interpreted by the brain. It is important to stress that once an image falls in the retina, the optic pathway and cortex will process the image based on a strict fixed spatial coordinate, meaning that when an image is captured at the correct retinal location, the image will then be correctly represented in the brain. But when the retina fails to capture an image in its correct position, the brain will also represent the image incorrectly. Now let's go back to our patient with right inferior rectus weakness. Let us first cover the right eye. The left eye in primary position will perceive the bar without a glitch. The image will fall in the fovea. The bar will be green since it is being viewed through the green crystal and at the correct location. Now let's uncover the right eye and represent, but not in the normal position as shown in this frame, but hypertropic as represented here. So in a hypertropic eye, the image meant to fall in the fovea at the eye equator will fall in the upper part of the retina as indicated here, and thus the red bar will be captured at the upper retina and as a consequence represented below the correctly placed green bar. So the answer to this question, why is the false image lower than the true image, is because an hypertropic eye displaces retinal images upward, which are perceived by the brain as lower. Thank you very much for your attention.